Hello, my name is Taybor Flores, and I am a fourth-year pharmacy student with Texas Tech University Health Science Center with the School of Pharmacy, and I'm doing this in-service over neonatal sepsis as part of my pediatric rotation with Dr. McKee. So going over some general facts over neonatal sepsis, we don't have a definitive consensus definition for neonatal sepsis. We just kind of know it when we see it. It's really a systemic condition where we see multiple organs and systems showing abnormalities that can be associated with the blood pressure, temperature, and other systems, as well as I will talk about later on. There are two main types of neonatal sepsis. We have early onset, which is less than 72 hours after birth, and a late onset, that is more than 72 hours after birth. And we really use these two terms that kind of help define what we're looking at, what caused them, and what treatment to use. So as far as its impact worldwide, this affects 3 million neonates across the globe and really shows the impact it has on healthcare in the pediatrics world. And even here in America, mortality is 11 to 19% if you have severe sepsis. So still a somewhat high mortality, and really shows the importance of this disease state. Going over what causes neonatal sepsis, a big causing agent is going to be group B strep, otherwise known as GPS, which is mainly seen in early onset sepsis. This is mainly going to be from an infection mom already has that can be tested before and after delivery. Also, if we see any signs of the fetus showing stress or amniotic fluid showing bacteria, we can go ahead and give intrapartum antibiotics to kind of deal with this before they come out of the womb. Also, just to go over this real quick, early onset is mainly going to be caused by anything that's going to go up the birth canal into the amniotic sac. And a big another infectious agent we look at for this is E. coli. This is going to be one we'll see a lot, which I know is associated with a lot of UTIs, mainly why we kind of see this here. Another agent is Listeria. Not a very common infection, but something that accounts for about 20% of early onset sepsis, so something to look out for. Then Staph aureus and Staph epi are associated with late onset sepsis, really due to anything that's going to access the vasculature, whether that be catheters or IV access. Go over that here in a little bit. Another agent we need to worry about is viruses. So herpes simplex, even though this is associated with STDs, this is what causes cold sores in your mouth. So if grandma or granddad comes and kisses the baby and have a cold sore and don't know it, they can cause sepsis. And then fungi, so candida infections are also pretty common causes for sepsis and something to look out for as well. So risk factors for neonatal sepsis, so big one is going to be prematurity and low birth weight. And this is mainly what we see to be really correlated with neonatal sepsis, which I know is a lot of our patients in the NICU. So that's why you may see prophylactic doses given for a lot of them. And specifically if they were born less than 32 weeks at gestational age, then they're not producing antibodies yet. And so they're going to be at really high risk for sepsis. On top of this, any invasive procedures, any surgeries, IV access, intubations, or an umbilical catheter can cause sepsis. So these kind of procedures should always be done under aseptic techniques and should always make sure that we are cleaning everything before we do these procedures to decrease the risk of sepsis. Also, low vitamin D levels have also been associated with early onset sepsis. I know this is not a commonly done lab, but it is something that is associated with sepsis. And then if the child is not getting breast milk, then they're not getting mom's antibodies, and that also puts them at risk. So if mom has a intraamniotic infection, otherwise known as chorioamnionitis, then this is the biggest maternal risk factor for sepsis. So if mom is showing any distress, any fever, high heart rate, high neutrophils or WBCs, and the fetus is showing a high heart rate, these are definitely warning signs of this happening and should be investigated further. Also, pre-labor UTI, if it hasn't been cleared, so that E. coli again can definitely cause this. If mom has a ruptured amniotic sac and is not aware of this for greater than 18 hours, definitely could see some bacteria making its way up to the unborn fetus. And then if they're positive for GBS pre or post-labor, we should be concerned about an infection. As far as diagnosis goes, these are a bunch of symptoms we see with these children. This is not a all-encompassing list, but the main thing I want to show with this slide is if we're seeing multiple symptoms within a child, we should not think of them as unrelated because they possibly could be related, and it could be sepsis in which we need to start antibiotics as soon as possible, really. So if you're seeing jaundice with a high respiratory rate and they're vomiting, they're not eating, they have cold skin, all these symptoms together are going to point towards sepsis. And to go ahead and discuss this right now, there is not a good scoring system for neonatal sepsis. So there has been studies before where they've looked at symptoms that children have had and try to rate those, and that doesn't have a lot of good data to support use. You can use a calculator, I believe on MedCalc, to have kind of an idea of if you need to start antibiotics or not without labs, but really to use that as a diagnostic tool for neonatal sepsis, it does not exist. There's just no good scoring systems right now for neonatal sepsis. Now, looking at lab tests, if we have a positive blood culture, that is the gold standard and positive for sepsis. So we would like to have 0.5 ml to 1 ml from two sites, so a peripheral site and then another site if they have IV access anywhere, and if they have a central venous catheter, we definitely need to get a sample from that as well. And I know I say simultaneously on this slide, but really that just means very close to each other. I don't need to try to get two samples at the same time. And then if we see any CNS involvement, we may want to get a lumbar puncture to rule out meningitis if the patient is stable enough for this. Otherwise, if there's no CNS involvement, it's really not necessary. And then when looking at CBC and specifically white blood cell count, so this is a really good predictor when we're looking at neutrophil count. Not the leukocytes or total WBC, but just neutrophils is a good predictor for sepsis. So if that's looking to be high, then we should start to be somewhat concerned. And we may see a lot of these kids have low WBCs because they do have a limited amount, and that will kind of go low. So you may see high neutrophils and then a low amount because they've exhausted that fighting this infection. And then COP can be used as a marker of the humoral or innate response, but the liver needs to be producing that, and that usually doesn't happen until day of life 2 or 3, so better for late onset sepsis. So here we have some preventions and non-pharm treatment we can use for neonatal sepsis. So breast milk is going to be the most important thing we can give these patients. They're really going to need the antibodies from mom in order to fight off infections and also build up that gut bacteria to help protect against any other bacteria that may try to invade the GI tract. And to go along with that, trophic feedings are also very helpful in order to get the GI tract moving and growing and decrease any other external colonization that we don't want that could cause sepsis. Now, probiotics can be used for this purpose, but in the studies, they never used the same probiotic, the same dose, or the feedings were different. So there's not a good recommendation on which one to use, but you can use probiotics and it should help get some good gut bacteria in there. And then lactoferrin is a breast milk protein that has been shown to have benefit in sepsis patients, but it's really not recommended yet. It's pretty controversial. Some studies say, yes, this does help. Others say, no, it doesn't, but if baby's getting breast milk, they're getting this as well. So once again, breast milk, super important. They should always get this if mom is okay with that. If not, may want to talk to mom and dad about adding in some of these probiotics and lactoferrin. And then as always, whether you're the parents, the nurse, or the doctor, wash your hands. Make sure you're using clean hands before touching the patient in order to prevent infection. Now we are on to the actual pharmacological treatment. So we have the antibiotics. So for empiric treatment, meaning we don't have blood cultures yet, they're not positive, we can still give these if we're looking at a septic picture. So not having cultures is no reason to withhold antibiotics. They should always be given if we're suspecting sepsis, which they may be given just based off of risk factors alone, just to decrease the chance of sepsis. So early onset empiric treatment, we're looking at ampicillin and aminoglycoside. I know right now at Hendrix we're using tobramycin, and these will be given for 10 days for bacteremia and 14 days for GBS or meningitis. If we do have gram-negative meningitis, that's when we'll use third and fourth gen cephalosporin, so the ceftazidime or the cefepime. And then late onset, we're going to use vancomycin and aminoglycoside. And then just of note real quick, if we're doing this prophylactically, they will only be done for 48 hours. So if after 48 hours we see nothing to show sepsis, we can go ahead and discontinue that and we'll be good to go. Now if we do have cultures back, here are some other treatments we can use. So if we have ESBL, so these are really resistant gram-negative bacteria, we can use carbapenems, which will more than likely be meropenem, though it's up to the provider. If we're looking at anaerobic infections, we can use any of these agents right here, clindamycin, unicin, or metronidazole. But if we're looking at meningitis with an anaerobic, we're going to use metronidazole. It has much better CNS penetration than the other agents. And if we're looking at a staph epi infection that is persistent, we've done the 10 days, it's still there, may look at adding rifampin. It has some pretty good data for add-on. And then some other things we can use, so IVIG or the colony stimulating factor. So if they're low on neutrophils or antibodies, why not just give it to them? And out of a lot of randomized control trials hasn't really been shown to decrease mortality or have good benefit, so we really don't use those. There's my reference page, and thank you all very much for watching. I'll have a great day. Thank you.